So let's move on to the next session, talking about very aptly mechanical support options for the right ventricle. And it's my pleasure to introduce Dr. Mahwash Kassi. She's one of our staff attendings in heart failure and transplant. Did most of her training here, fellowship, and then went to Mayo Clinic, trained there for advanced heart failure, and joined us back. Didn't like the cold, of course. But she's actually been rounding and taking care of patients in the ICU. She's going to do a case-based discussion for RV support. Mahwash, thank you for doing this.
Good afternoon. It's my pleasure to give this talk today. I'm sorry towards the end of the day, but I was told since there is going to be a panel to rather have some case discussions and a few cases. I've left the different devices and some evidence based on what they are towards the end, and if it gets too long, then I'll stop. But we'll do some interesting cases at the beginning. So 3D view of the RV. My objectives today is basically to utilize this session and try to figure out the pathophysiology of RV failure and why do we need percutaneous devices in these patients. Evaluate the various percutaneous and surgical RV support devices. My focus is going to be more on percutaneous devices than surgical ones, but I will touch upon that briefly also. And then talk about some of the evidence base. There's not a lot of evidence. I want to put that out there, but there is some, and there are some studies that have been done recently on percutaneous devices. So this is the life of a heart failure cardiologist whenever an RV failure occurs. We see it very commonly, particularly from our VAD population, and then also patients who present with cardiogenic shock. The way Methodist Hospital set up is we're not only heart failure transplant cardiologists, but we're also shock cardiologists, so we do see a lot more shock, and particularly RV failure presenting as shock also. So it remains a major cause of global morbidity and mortality. And we see this in different patient populations, particularly advanced heart failure. We all know about patients who have biventricular heart failure. Pulmonary hypertension. I think the most common scenario I remember from the days of med school was acute MI and RV failure as a result of that. And one other thing was, which is a major cause of morbidity and mortality, is major cardiac surgeries. And I'm not talking about just VAD surgeries, but I'm talking about bypass surgeries and valvular heart disease. When patients undergo those surgeries, they're at risk of having RV failure. RV failure is particularly dangerous in the short term. It increases mortality quite a bit, and you have to act on it rather quickly because of that reason. RV acute mechanical circulatory support now represents an important step in the management of the RV failure, and I'll go over some of the medical management, but as I said earlier, my focus is going to be on mechanical circulatory support. This is what I like from one of the recent statements on RV failure. As experience with RV devices grows, their role as mechanical therapies for RV failure will depend less on the technical ability to place the device and more on algorithms for identifying RV failure, patient monitoring, and most importantly, weaning protocol, because now you have somebody who is on an RV device, and what are going to be the next step is actually a very hard part of dealing with patients who have mechanical circulatory support in the RV. So right ventricular failure, etiology, the way I think about RV is, so you either have a problem with the pump, or you have a problem with the valve, or you have a problem with the conduit. And then when you're a VAD cardiologist, you also have a problem with the septal interaction. And I'll go over some of those scenarios. And that's the most simplistic way to think about it. And in the next couple of scenarios, I'll remind you which particular problem we're dealing with. Is it the pump, is it the valve, or is it the conduit? So going on the same concept, physiologically, that means that if somebody presents with a MI or has myocarditis, they have pump failure, so they have contractile failure. If somebody who has valvular insufficiency, and we see that in patients who have tricuspid regurgitation, they can have volume overload, and you may think that their left ventricle is doing okay, but they still have low cardiac index, and that's because they have profound regurgitation from the valve. And that's an important piece that we miss a lot, and don't think about low output in those situations. The third one is, of course, something that I deal with very often, is septal deviation from an LVAD. Once the inflow cannula just pulls the septum towards it, It can cause acute RV failure, and I will go over that also briefly. And then pressure overload. We think about this like pulmonary hypertension, acute PE, and biventricular failure in the case of patients who have, let's say, non-ischemic or ischemic cardiomyopathy and have biventricular involvement. So the temporary RV support devices options, there are some people who still think that, or theoretically, we say that if you put an intra-aortic balloon pump in patients, if you reduce the LV afterload, we are also reducing the RV afterload and hence helping the RV. But I'll go into the concept of refractory RV failure or refractory to medical therapy RV failure, which is not helped with the balloon pump. So balloon pump, in my mind, is not a durable device that would help the RV hemodynamics that much. The ones that are available are now the IMPELLA RP, the TANDEM Heart, RVAD or PROTEK Duo, and the surgically placed CENTRIMAG. So this is case number 1. I have made these cases short just for interest of time. If there are any questions from the audience, please go ahead and ask. 69-year-old, this is a patient transferred from University of New Mexico on peripheral VA ECMO. So we're already talking about somebody who's fully supported. So here the physiology gets really crazy. Initial presentation to the hospital in New Mexico was for shortness of breath and dry cough. The imaging was done initially, and they thought it was a PE, so the patient underwent TPA. However, she didn't improve, and further imaging, they looked at it a little bit closely and realized it was actually a tumor. And then, I don't know if the audience knows this, but we are a center of excellence for cardiac tumors, and Dr. Reid and Dr. MacGillivray do some resection surgeries here. So this patient was transferred here for resection of the cardiac tumor. She had resection of the right ventricular outflow tract, the main PA, and the branch pulmonary arteries, and reconstruction of the right ventricular outflow tract, the main PA with 26 millimeter homograft, and the branch PA with an 18 millimeters Dacron graft. Now, we were consulted because there was inability to wean ECMO, and she was in a state of shock despite being on multiple inotropes and pressors and being on ECMO. And her ECMO flows were around 2.5 liters with an RPM of 2990 and sweep of 2.5 liters. If you don't understand this jargon, doesn't matter. But she was fully supported. Her echo, she had newly depressed EF. That was the echo read, and the EF was 30 to 34%. And this is her echocardiogram. Can we play the images, please? So what we see here is this. There is a squished structure, and there's a structure that's huge. So there is an underfilled small left ventricle with an underfilled small left atrium, but the right atrium and the right ventricle are huge, and the septum is completely deviated towards the left. Now, the second image, which has the short axis view, is when we cut the heart in kind of a short axis kind of way. So the smaller circular structure is the left ventricle, the bigger structure is the right ventricle, and the right ventricle again is huge and pushing over or squishing the left ventricle. That's my simplistic way of explaining this. I know that not everyone in the audience is an echocardiographer. And can we play these also? This is a view where we'll assess for the right ventricle also. The structure on top is the right ventricle, the structure at the bottom is the right atrium, and the flow that you're seeing is tricuspid regurgitation, blood flowing from the right ventricle into the right atrium. And this is the TR-jet, and we use this to estimate the PS systolic pressures, and in this, the estimated PS systolic pressure was 80. So now we have somebody who's on full ECMO support, and we have this echo finding. To the panel, my question is, what would you do next?
So I think one of the aspects so this is after surgical resection, right? After
Correct.
Surgical resection.
After surgical resection.
And you're on full central ECMO support.
Yes.
So what are the things
peripheral ECMO support.
Peripheral ECMO support. That RV looks terrible, but I think, is it remodeled over a period of time, or was it an acute insult on top of it, is an important distinction to make. But also, if you're on a full support, for you to have a PA pressures in the 80s, I mean, pressure is either flow or resistance. And if you're flowing fully and you're still having all that pressure, there's some kind of a high enough resistance that you would probably worry that the blood, when it's, especially if it's a peripheral ECMO, the blood's going into the RV and then through the PA. I'm not sure how much it is going back into the LV, especially by your ECMO. It looks like an acute PE echo. The echo looks almost like there's no blood going into the LV. But that's a high resistance in my mind, because if someone has RV failure and you put them on ECMO, you would expect some amount of decompression, unless it's a acute process.
I'll let Dr. MacGillivray finish up here because I'm sure he knows the answer. But anyway, so a couple other important points with this peripheral ECMO. Of course, we're limited on time, but the position of the cannulas, are we draining the right atrium efficiently? So the circuit itself has to be in good shape. You're flowing good, and your numbers looked all right. I agree with Arvind. The one point I would make is that this is post-operative. So I'd have to ask myself, the surgeons that did the surgery, is there anything that could be obstructing the flow of blood? It's a simple plumbing, right, into the pulmonary vascular bed. So I'll go ahead and let Dr. MacGillivray finish up here.
Yeah, I think a common misconception that many people have is that ECMO, either peripheral or central, decompresses the heart, and it doesn't. It really just allows circulation in the systemic circulation. And you won't, if you look at pressure volume loops, they really don't change on ECMO. And so if you have a compromised dilated ventricle that is not from acidosis or poor perfusion, you may not get not only good decompression of the right or left ventricle, you also won't get good recovery of the right or left ventricle. It's a good way to keep the patient alive. It's not necessarily a good way to get the ventricles to recover unless you do something differently, like decompress them.
Tom, I think you brought up a good question. I got to go and do some simulations in the PV loops. But if you think about it, and this is a unique situation, your LV doesn't get decompressed because of arterial afterload, because you're sucking blood from the venous circulation and pushing into the arterial. And that's an important concept to recognize for anybody who uses ECMO, because what Dr. MacGillivray is talking about is we have a false perception that the blood pressure is high, because in an ECMO, the blood is being sucked out of the venous system and pushing back into the arterial system. But that arterial flow and pressure is what an LV has to pump against. And especially if you put in an ECMO for a weak LV, that is going to be high resistance. Now, the right side technically shouldn't be seeing that resistance unless it's back flowing into the RV. So this is a unique situation where it's not bad LV, they put it in for a bad RV. And I mean, physiologically, the resistance will probably backflow into the RV. But it's interesting in these situations, even if you decompress the LV, I wonder how much resistance will pass on to the RV.
Well, unlike cardiopulmonary bypass that we use to do heart surgery, we have a reservoir. We can actually drain the blood out of the right side of the circulation into a reservoir. And so if you look at the right atrium and the right ventricle on full cardiopulmonary bypass, it gets sucked down like a raisin. That does not happen with ECMO. Just the blood just keeps circulating around it. In this particular patient, one of the problems that we had with her was that she had HIT and she thrombosed her conduit, which is an interesting problem. Translate that into a bad problem.
You're letting the cat out.
But I still think it doesn't change the
I think she was holding that story for the next slide, looks like it.
Oh, is that right?
You spoiled it for us. That's good.
It's okay.
That's segue. It's a good segue.
It's a good transition.
Yeah. I'd like to retract that last statement.
It's on social media. It can't go away now. So like I was talking about earlier, so it's either the ventricle itself, the pump, or it's the valve, or it's the conduit. So those are the big three reasons why people have RV failure. So, I'm a younger attending, and for me, I need more information. So we pushed and dragged this patient who was on a lot of support on ECMO in the cath lab and wanted to do a SWAN. And of course, I could never pass the SWAN beyond the PA, and I had to call my fearless leader, Dr. Bhimaraj and Dr. Kleiman, benefits of training in the same program, and they came to the cath lab to help, and even then they couldn't pass the wire or the SWAN across from that PA. So at that point, we knew there was some kind of obstruction that we're dealing with. Can we play the image, please? So as you can see, everybody can see that there is contrast. The RV is contracting, but actually there is no flow beyond the cutoff point that you see, and there is no flow to the lungs in the pulmonary vasculature. So this was a unique situation where, not only did I see high resistance, I saw complete obstruction. Which, if you think about it conceptually, if you had high resistance, kind of behaves like that physiologically, but here you're seeing complete obstruction. There's actually no flow. And then that's why we were seeing an underfilled left ventricle. The echo was deceiving here because we saw all the blood being, sent back into the right atrium, and we were seeing PS systolic pressures in the 80s. And if we had gone by the echo, we would have completely missed this diagnosis. And so from the cath lab, like Dr. MacGillivray said, the patient went to the OR, and they tried to remove that clot over there, but unfortunately she had HIT, and her prognosis, being in shock for that while, was to begin with poor. But Dr. MacGillivray, if she were to live and if we were to offer her some kind of device, or in this situation, if you have somebody who has high resistance, would you think that you would consider some kind of an extra device to help vent the ventricle?
Yes. Yeah, so some kind of right ventricular assist device with their chest open. We had, consider putting a CENTRIMAG in, or if it were a different circumstance, I think putting in a PROTEK duo or a right-side IMPELLA would have been a good situation.
But I guess that's after relieving the obstruction.
Yes.
After relieving the obstruction.
Yeah.
So that was one very bizarre case, but I don't think I'll ever see that kind of situation in my life again. But
I hope not.
But next time, if I see a similar situation, I know what I'm dealing with. Case number 2 is more run-of-the-mill, but this was a young 45-year-old female who was referred to our hospital for evaluation for advanced heart failure therapies, and she was listed prior, but then she started doing well, and this is where the young deceive. And she was being seen as an outpatient, and for the second time around, when she started doing poorly, we were considering for advanced heart failure therapies. Unfortunately, she then presented to the hospital with recurrent VT and was in cardiogenic shock. So on arrival to the cath lab, her math was in the 50s to 60s kind of range. She, at that time, was fairly decompensated and couldn't even lay flat for her cath procedure, and she developed much worsening pulmonary edema and rapidly decompensated just in the cath lab. So at that point in time, I just want to give a little background of echo. I'm an echocardiographer, a little bit at heart also, so images help. So this is a personal long view showing the left ventricle and diastolic dimension extremely large. 9 centimeters was her LV and diastolic dimension. And as you can see at the top, the RV is overlaying the LV, and the RV also doesn't move much. The second image is a four-chamber view. Again, the LV, you can actually see stagnant flow in the left ventricle because the LV is so dilated and weak. And similar goes for RV. If you look at the excursion at the tricuspid valve, there's very limited excursion. So she had essentially non-ischemic cardiomyopathy that involved both ventricles with very concerning features. This is a view I actually like. This is subcostal. We usually don't see it, but if you look at the interatrial septum in the subcostal view, her interatrial septum is completely abutting in the right atrium, meaning that her left atrial pressures were far higher than her right atrial pressure. But this is also somebody whose right atrial pressure, if you look at the IVC, was also very high. So the cath findings that I have are not surprising. But I guess if anybody was to make a record of cardiac index, it was her in my short career. She had an RA pressure that was 23, her mean PA pressure was 49, her veg was 42, her blood pressure at the time was 55, and her cardiac index was 0.9. So at that time, as she was decompensating and doing poorly and had pulmonary edema, I initially placed a intra-aortic balloon pump, but it didn't seem like that it helped her a whole lot. And at that time, we consulted with our interventional colleagues, and they insert IMPELLAs. So they inserted an IMPELLA CP, and her RA pressure at that time was again 23. Her mean PA pressure was 41. Her veg reduced somewhat, 30 after 20 minutes of being on the IMPELLA. MAP improved, 70, and cardiac index improved to 2.1. So at this point in time, our interventional cardiologist asked me whether I think we should put an RV support device or not. And my question to the panel is, would you consider a right-sided support device here?
Is she on a lot of pressor support still?
So she came in, and at that time she was she started on dobutamine in the cath lab, so she was not on much pressor support. But as we were continuing to manage and waiting for her to get into the ICU, she was intubated. She was started on many other drips, including inotropes and pressors at that point in time.
And your PAPI looks like is going to be bad, right? The PA pulsatility index. I'm bad at math, but if you do
it's around 1.
Huh?
Around 1.
Around 1.
Yeah, so I had a question. Let me ask you this about the decision with I know you're in the cath lab, the patient's not doing well. I mean, of course, we have the IMPELLA 5.0, right, which will provide more blood flow. Is this patient stable enough to go to the OR for a more robust left-sided unloading? Do you think that would make a difference as it relates to the right side?
I would say in retrospect it would have, but she was extremely unstable.
Well, hindsight's 2020, so
yeah.
So the cath lab's a little better place. So you're asking, should we put additional support, such as on the right side? And I'll let Dr. MacGillivray comment. I think at this point you may want to consider maybe doing a percutaneous right-sided device. I mean, you could put a PROTEK Duo in the cath lab. You guys can do it. That'll be my first choice if you can do it. Otherwise, you could put the IMPELLA right-sided support.
So, of course, this was a situation where I thought, no, a cardiac index has improved.
But also, I think, let me challenge that thought, because this is where, if you talk about, when you look at the echocardiogram, you see the left atrial pressure so high, the left atrium is bulging into the right atrium. The LV is dilated, RV is dilated, but not bad. So you can postulate that the wedge is still 30. It's not 40, but it's 30. If you support the left side enough or continue to maintain better left-sided support, will the RV do okay, or should we go ahead and commit, right? I think that's the debate you're having, because right-sided supports come with a caveat, and I don't know what we did, but also when we talk about which support to use, the right-sided supports are not that easily prevalent. If you're going to touch on the available pumps later.
Right.
Okay. Yeah. So we'll wait for that. No, go ahead.
I mean, she's clearly better than she was, but and I think that you could get wooed into a false sense of security that her cardiac index is better, but I share Arvind's concern that the wedge is still 30 and the CVP is still quite high, in that you may have she still may be a house of cards.
Yeah. And I guess at that point, like Dr. MacGillivray, you mentioned that I had that false sense of security, thinking that we are doing a little bit better, and I told my interventional cardiologist, no, let's just hold off. And you know, there is that hesitance also to like think about putting these devices in right off the bat on patients, and she's a young girl, whether I want to do a percutaneous device right there and then. The other major issue with her was that she had complete obstruction of her IJs, so we couldn't do a PROTEK Duo in the cath lab anyways, but we could have considered an RPE IMPELLA, but her swan was in her groin as well as the balloon pump, and the other new CP IMPELLA was on her left groin. So that was kind of what also swayed the decision, but she unfortunately didn't do well. And then she had overnight rising CVP, worsening hypotension. She was on increasing pressors with minimal improvement. She went into florid end organ dysfunction with rising liver function tests and renal failure and lactic acidosis. And then I had to give a call to our ECMO experts here, Dr. Bruckner, and then an ECMO was placed at the bedside. And she stayed on ECMO support for 2 weeks, but there was no improvement. And unfortunately, we had to eventually withdraw care on her. So the lesson, at least for me, I learned here was that maybe early RV support could have helped this situation, and maybe she wouldn't have died.
So one could argue that we should have done an ECMO support up front. Right? I think ECMO is an aggressive measure, but so is a BIV support. And again, I don't have a right answer because everything that we do are at higher risk interventions. The only editorial I'd add to that statement, which is very fresh off the press that Barry shared yesterday, is there are two devices for support, IMPELLA right side support and then PROTEK Duo. IMPELLA right side support, FDA just put out a letter saying it was approved as a humanitarian use because there was no right-sided supports, but they put out a letter saying that of the reported events right now, the mortality has been much higher in patients who have RP. Now, is it patient selection or not? I don't know. And then you bring up these logistic questions, which are very relevant. One could argue if you're going to wait and watch how things are going to happen, you can put in a PROTEK Duo and RP is questionable. Should we have just done an ECMO?
Well, that's a good point. I was thinking about it too, and maybe we could have acted. Or this is hindsight's 2020, right? So we're in the cath lab, right? You already have technically a vent in the LV, so you're venting the heart as best you can, even though you still have a high wedge. You could put the patient on peripheral ECMO, and the only reason that's not going to be your permanent solution, but what that would do is give you some breathing room, some time to stabilize that patient, and then figure out where you're going to go from there. Otherwise, you sit them over in the ICU, and they start to deteriorate, they get acidotic, and then you're way behind the 8 ball.
Right.
I think you want to differentiate between rescue and recovery.
Yeah.
And I think that ECMO is a very good, quick, effective way to rescue someone. But at least in my opinion, I don't think it's a good way to, as I in my comments earlier, a way to recover someone unless there's something that's going to get better by itself.
Yeah, I think the bigger themes that you're bringing up is it's all good in the moment. The part that we struggle with is where are we heading next? Are we going to be able to recover? And this doesn't sound like a recovery scenario where you're coming with myocarditis, you can treat. So then the next phase is going to be bridging to LVAD or transplant. Those are discussions that we have, and it looks like in the heat of the moment when you don't know the future, we give the benefit of doubt and then do these things. And as time goes by, appropriately, if there's no meaningful recovery, you will reach a limit of palliation or hospice, and it looks like that's what happened after a while.
Right. The third case is somebody who's 32-year-old with non-ischemic cardiomyopathy and cardiogenic shock. Initial support system was a balloon pump. Subsequently, that wasn't adequate, so we did an IMPELLA 5.0. And then finally, because they were in cardiogenic kind of shock phase for a long period of time, we decided on durable LVAD, HeartMate 3. But we knew going in that this was also somebody who had biventricular failure and that RV was not great to begin with. But post-operatively, when the patient was being run at 4,600 RPMs, developed hypotension, elevated CVP, and low cardiac index, the trifecta of RV failure that we see. One little caveat I want to add here is that whenever people develop hypotension with elevated CVP and low cardiac index, people start doing vasopressor on them to elevate the blood pressure and get that better, which is what started in the ICU when the patient was there. But to be very honest, like I've seen in all these RV failure situations, when we start kind of taking care of the issue of RV and maybe start nitric oxide in this situation, the blood pressure counterintuitively immediately gets better. Or if it's a suction, if you relieve the suction, the blood pressure gets better. So it's not so much of a vasoplegia issue, but it's actually the RV issue, which is important to recognize, and it's a little counterintuitive when you're managing these patients. So again, my sonographer was at the bedside, and we at that time we stabilized the patient with doing some nitric oxide and reducing the pump speed. But I wanted to see exactly what happens at that 4,600 RPM. So we kind of reenacted the same situation again. So we were down at 4,400, and here you see that the LV is nice and big, and the RV is doing its own thing, and there's no inflocanna that you can see in the peristernal long axis view. But in the subsequent view, you see that when we increase the speed to 4,600, the entire LV, which is quite big over here, this is a patient whose LV size is around 7 centimeters, completely collapsed, and the RV ballooned out. Everyone was a little freaking out, and I was taking images at the same time, but before we circumvented the situation, I wanted to make sure that I get this on imaging document, because it's extremely important to understand the concept here. And subsequent to that, we went down on the speed and the whole thing shifted back in midline. So this is the septal interaction that I was talking about, that when you have somebody who has an LVAD and you have a complete suck down, the key here is not to start giving more pressors. The key here is first to drop the speed, because you know that the septal interaction has been compromised, and see if that relieves that situation. And if that doesn't help, then we can always start nitric oxide or consider an RV support device. So this is the very drastic echo. This is another view. Can we play this, please? So this is somebody, same patient, but in a different view, where you see that the LV is completely collapsed and the RV is ballooned out. This is just a different view where you see that completely collapsed LV, and then the RV is humongous. So the RV completely overpowers. This is my simplistic drawing. I think what I was trying to demonstrate here, the inflow cannula position can actually, one, you can have a complete suction, so your RV, your septal wall can completely shift towards the RV. When I was making that drawing, I never thought that it would be that drastic, but I've seen now this is the worst possible case. And this usually happens in the acute phase, because now it may be something to do with the heart's not used to having an inflow cannula, and not used to that having that interdependence relationship between the LV and RV. I guess I can skip the physiology part, and we talked about that, but recognition, poor perfusion, low cardiac output, JVD, congestive hepatopathy, these are the things. And it's pretty drastic if at the bedside, if you see somebody whose chest x-ray is clean, but they have hypoxia and they're having elevated JVP, or usually now we have SWAN catheters and CVP is rising, you know that you're dealing with RV failure. Echo is helpful, but invasive assessment is needed. If your CVP is greater than 16, now we're used, at least in our clinical practice, we use our RA to veg ratio to kind of guesstimate whether we're dealing with RV dysfunction or not. So if your RA to veg ratio is greater than 0.86, this was in a study for acute MI, or greater than 0.63 after LVAD, you're dealing with somebody who has RV dysfunction. RV stroke work index is too complicated for me to calculate, so I usually don't use it. But the one that I do use is PAPI, which is very helpful, which is PM systolic pressure minus PA diastolic pressure divided by your RA pressure. And if that less than 1 for acute MI and less than 1.85 for after LVAD was shown to be associated with RV failure. Or these are a list of all the formulas, but sometimes none of these are helpful, and you have to go by more than one method to calculate. But knowing that these are there, it's helpful. So the two I think if you were to take home from my talk would be the RA to veg ratio and the PAPI. That's helpful. Medical management, optimization RV preload. We were taught in medical school to give fluid, I think, at the time of RV failure is what I remember. But volume expansion is important, but also if there is a limit to it. And also if you start going above a certain CVP, then diuretic therapy is important. But then that's where the beauty of SWAN is, that you have to have one-on-one measurements. And reducing the RV afterload with pulmonary vasodilator, so the role of nitric oxide, that's typically what we use in the first instance, and then inotropic support with milrinone dobutamine. And then management of radiated arrhythmias, people forget about the heart rate, so what I do is if they have a pacemaker, increase their heart rate to like 80s or 90s to kind of give them some forward flow. And if despite all these measures, now still they're hypotensive, then you could probably consider using vasopressors. There's a study done which was kind of interesting about the whole concept of volume expansion in the CVP. So several studies have now shown, like if you want to keep your CVP in a good range, maybe consider keeping it between 10 to 14. So yeah, if you're in single digits, maybe you want to consider, if you're like having a CVP of 3, maybe give some volume, because RV is dependent on volume also for forward flow. But also if you're starting to have like CVP greater than 15, don't give more volume. That's not going to help the RV. You're going to flood the RV more. So that balance is important. Back to what I was going to talk about initially, so the IMPELLA RP, the TANDEM, RVAD, or PROTEK Duo, and the CENTRIMAG. So CENTRIMAG is the one that is commonly used. It's surgically placed. You have to do an open sternotomy or a thoracotomy for this. It's typically coupled to the ECMO circuit, and it achieves 6 to 8 liters of flow. The FDA approval is for 4 weeks of support, but I'm sure we've seen longer than that, right, Dr. Bruckner? CENTRIMAG, we use it for longer than in our clinical practice.
Yeah, there's sub-centers that can close the chest. There's a strategy where you can put grafts and close the chest, but yeah, that's
I have
another
exceeded my time anyways, but I will say one thing that this graph is kind of important is that when you put on the CENTRIMAG, it's important to recognize that the flow is dependent on the pressures also. So it's more helpful in patients with acute RV failure than in patients with pulmonary hypertension. So that's an important concept, and if you all want to maybe revisit that at a later point, be helpful for clinical practice. So IMPELLA RP, the TANDEM, RVAD, the PROTEK Duo, and the and then VA ECMO, of course, is not something I'm going to talk about, but these are the way they categorize the RV support devices by direct RV bypass or indirect RV bypass. Direct RV bypass is basically saying that you're pulling the blood, there's a connection RA to PA, so basically pulling in blood from the RA or dumping in the PA, kind of that relationship is there. But in indirect means that you're completely bypassing that RA to PA relationship. These are the hemodynamics that, Dr. MacGillivray touched upon some of the ECMO-related hemodynamics, but it's important to recognize what would be the effect of putting a right-sided device on the left side. And before you put a right-side isolated device on somebody on the left side, it's key to recognize what the left ventricle is doing. If the left ventricle is normal and does not have, let's even say, diastolic dysfunction, isolated right-sided device, may not have significant hemodynamic effects. But if you're dealing with somebody who has RV dysfunction and LV dysfunction, keep these hemodynamic parameters in mind. And since for the lack of time, I'm not going to go over each individual one, but it's a helpful thing. Balloon pump I already touched upon, and I don't think that's to think that that would help the RV is not the right way to think about it. So this was a definition for refractory RV failure, which is defined as cardiac index less than 2.2 despite continuous infusions of high dose of inotropes. And they define the dose of dobutamine and imilranone, and or administration of greater than 1 inotrope or vasopressin medication plus any of the following, which is CVP greater than 15, CVP to VEG ratio that we've talked about earlier, and the global RV dysfunction echocardiography. These are patients that when you have such a patient who has persistent low cardiac output and you're dealing with a lot of inotropes and vasopressors, and despite that you see the hemodynamics that are poor and their CVP is still high and their CVP to VEG ratio is still greater than 0.63, then you would consider a right-sided support device and consider it earlier on. This is an IMPELLA RP, the 22 French pump on an 11 French catheter. It's implanted from the femoral vein with a 0.025 wire, and then it has a peel-away femoral vein sheath. Inflow cannula in the IVC, outflow in the PA, flows up to 4 liters and at 3,000 RPMs, and ACT goal 160 to 180 during operation. Current indications are for MI, orthotropic heart transplant, or cardiac surgery. The caveat here is that you cannot use it to oxygenate. So that's an important difference to remember. So if you are suspecting that somebody who will develop issues with oxygenation later on, IMPELLA RP is not going to be your friend for that. And you'll have to consider something different. This is showing a cath image and then followed by the TE showing where the relationship of the catheter to the pulmonary valve annulus around 4 centimeters. This was the Recover Right trial that I was going to talk about. It's the best we have, and after that there's another trial that was followed up that showed the pooled results. I'll just go over the conclusions of these trials, but basically what they said is in this trial the hemodynamics improve, the cardiac index improves, the CVP improves, and overall survival improved compared to not having a support device. But there are safety issues, of course, major bleeding. But I would say, these patients are prone to bleeding anyway, so, not sure if that, would stop you from considering a right-sided device. This was the second follow-up study, and I guess I'm going to skip that, but the overall outcomes were similar. Just touching briefly on the tandem heart, the TH-RVAD and the PROTEK Duo. It has a 21 French inflow cannula in the RA via femoral vein, and a 21 French outflow cannula in the main PA. So these are big catheters. And deployment using multiple exchanges. The outflow tip, cannula tip in main PA above the pulmonic valve plane is where you put it. And there is a small registry, called the THRIVE registry, that went over the tandem heart data and showed some benefit in patients with RV failure. However, the results are not as good as an IMPELLA RP if you compare, but it's a retrospective study where the IMPELLA RP study was a prospective study, so it's not, you're not comparing apple to oranges. Again, this was the details of the trials. Now, PROTEK Duo is something that it has a dual lumen catheter with total 29 or 31 French sizes. It's a series of inflow vents, has a multi-fenestrated distal outflow tip. This can be spliced into an oxygenator, and so can the TANDEM RVAD. They can be spliced into an oxygenator. And it's capable of flowing about 4.5 liters of flow. ACT has to be running around 180 to 220. I've inserted 2, and it feels like stabbing somebody's neck with a huge hose. So these are huge catheters, and so is the tandem. So those things have to be considered. Like if you have somebody's anatomy who has narrow IJ, or these are big catheters that you're putting inside them. This cath images of how the tandem is PROTEK Duo is inserted. Again, limited data, we don't have a lot, but some series showed 41% mortality, and 23% of the patients were weaned off. I know. So this is the summary: acute RV failure, early diagnosis of RV failure, assess LV function, and then if there is a reversible cause, try to treat it, optimize preload, inotrope, and consider vasodilators, and if they have worsening hypertension, then have a heart team, initiate RV support early with either IMPELLA or tandem. But important thing is that you have to have an exit, as Dr. MacGillivray earlier mentioned, that you have to think about what kind of exit strategy you're looking at. And then most importantly, if you're putting an right-sided device, know what the left side is doing, and have some kind of strategy for the left side as well. Thank you.